Hello and welcome to tonight's Immunisation Coalition webinar on Influenza Update 2026. A very warm welcome to everybody who's attending tonight. My name is Andrew Minton. I am the CEO of the Immunisation Coalition and I'm really delighted to be moderating tonight's webinar. A little apology in the beginning. I'm responsible tonight for the IT. Our events manager is not here tonight, so I'm going to do the best I can. So there was no lead-in music because I didn't know how to do it. But the polls I think I've got sorted, so hopefully they will go as planned. So I'd like to acknowledge the traditional custodians of the various lands which we work today and welcome all Aboriginal peoples that may be on this webinar or may view this webinar over the next coming weeks as this is a recorded webinar. I'd like to pay my respects and on behalf of the Immunisation Coalition to elders past, present and emerging and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the various lands, animals, and waters of Australia. Presenting tonight, many of you know already Angela Newbound, who presents a number of webinars for us, but also she presents at our on-site meetings at the ASM and AIF and primary care infectious disease meetings, but also contributes to clinical newsletters and podcasts as well. And she also contributes to other organizations and companies talking about immunization. So Angela will present for about 40 minutes, which gives us plenty of time for questions. If we don't get around to answering all the questions, we will provide written responses together with a link with the recorded webinar in about a week's time. So nothing was lost. And it gives us a bit of time to think through, a more thorough answer to your questions if needed. If you want to ask a question, can you please put that in the Q&A so I can look at that, and Angela might also look at that. But feel free to use the chat function to talk amongst yourselves. I'll also have a look at that a little bit as well. And you may have questions that other people can provide answers to. So tonight's presentation, as I said, is recorded. So everyone will be on mute, otherwise it'll be a bit chaotic. So I managed to get that right. The evaluation form, we're going to have to do that in the morning because I don't know how to reconcile a Zoom account, everyone's email address to send out the evaluation form at the end of this webinar. So I've done the evaluation form, I just don't know how to send it out. So apologies for that. So really just like to introduce tonight's guest speaker, Angela Newbound. I've got it on my sheet here, I could just read off the actual presentation. But Angela Newbound is a nurse. Is a immunisation education consultant based in South Australia and has been actively involved in immunisation programs for over 25 years. Um, uh, she has been involved in program coordinator roles, as I said, in the divisions of general practice, SA Health Immunisation Section, the Medicare Local Network, and the Adelaide Primary Health Network up until the end of 2024. Angela continues to provide clinical advice and nurse education consistently throughout the year across a variety of platforms, and some of those I've just mentioned, and is very passionate about vaccination and immunization across all age groups and the role that immunizers play in vaccinating the general public. So with that said, I'd like to hand over to Angela. I think I can manage that. And for Angela to take us through her presentation, which I've reviewed, looks fantastic. And we'll start this evening's presentation proper. Thank you, Angela.
Perfect. Thank you very much, Andrew, for that kind introduction. And I'm sure that you'll manage the IT stuff really well, probably much better than I would. And I'd like to just welcome everyone for for joining, and thank you very much for joining and spending an hour of your precious evening time with us. So we're going to actually start. We're going to test Andrew a little bit here with a poll. You've just heard all about me. I'd like to know who's online listening to us tonight. So if you can just take a little minute, the poll's come up, and just tell us exactly, what title you wear. We'll give you a few minutes, a few seconds to do that. Perfect. Wonderful. All right. So mostly nurses, but we've got a beautiful assortment. We've got some GPs or medical practitioners and pharmacists on board, other healthcare workers, researcher, educator, and a few others. That's fantastic. So thank you very, very much for joining in. Perfect. Okay, so we shall get ourselves started. Look, I think we know influenza pretty well, really. Contagious respiratory illness caused by influenza viruses, infects the nose, the throat, and sometimes the lungs. They're a really significant human pathogen that can cause either seasonal influenza or periodic and unpredictable pandemic outbreaks. We know that influenza viruses can infect any individual at any age. It doesn't matter whether you're healthy or unwell. It doesn't matter whether you're rich, whether you're poor. It doesn't matter. It's completely indiscriminate. We'll chat about the signs, the symptoms, the complications of flu shortly, but I think it's really worth noting that a systematic review of published studies describing the relationship between viral shedding and disease transmission, was undertaken back in 2014, which found that 1 in 3 influenza-infected individuals was asymptomatic. So disease can look very, very different in each individual. And I think we need to really remind people that people can be asymptomatic and be infected with flu, because we hear time and time and time again that, well, I don't get a flu vaccine because I've never had the flu. And, sometimes I just sort of go, well, unless you've had a swab up your nose every single day of the year, testing for flu, you actually may not know that you have ever had flu, just because you didn't get sick, just because you didn't have symptoms. So these are the people, if they get infected, they're going off to work, they're going off to the pub, they're going off to the gym, they're in the schoolyard, because of course they don't think that they've got an infection, but they are actually infecting other people that they're coming into contact with. So I think it's really worthwhile reminding people about that. This is a really tricky virus. It's a very smart virus. We certainly know that we've got hemagglutinin, we've got neuraminidase, and that they really play quite critical roles, and these are these protein spikes, if you like, on the surface of the influenza virus cell. So hemagglutinin is sort of one of those spikes that's found. It sort of tends to bind onto the monosaccharide sialic acid, which is really present on the cells of the surface of the host cells, so of our cells. And so it sort of initiates this, endocytosis process, I suppose. The main function of neuraminidase is a little bit less understood, but it seems to play a role in removing the receptors for influenza virus from newly formed virus particles, allowing these to be released and to spread the infection around. So in the short of that, I suppose hemagglutinin helps attach to the cells in our body. It opens up, allows the flu virus into the cell. The neuraminidase then facilitates that replication process and that budding out of the cell. And then all of those new viruses that have just been replicated go on to infect more and more cells. So people certainly can become quite unwell with influenza. So we know that, there's influenza viruses. They're classified antigenically as types A, B, and C mainly. Influenza A viruses and influenza B viruses, though, are the ones that are more clinically important and are the ones causing more significant human disease. Influenza C, a little bit more like a common cold, often seen in children, but it's not a reportable infection like influenza A and B. So we know that both of these A and B viruses undergo really frequent changes in those surface antigens, and including those stepwise mutations of gene coding for hemagglutinin as well as for neuraminidase. And this really results in that cumulative change in influenza antigens, or that antigenic drift. And this is what's really responsible for these annual influenza outbreaks and epidemics of influenza, and certainly the reason that the composition of influenza vaccines requires annual review, just because of that antigenic drifting all the time. But of course, then we've got antigenic shift. And that really occurs when, there's been a radical or an abrupt change in the influenza type A virus hemagglutinins. And, we can, have examples like, H3, so hemagglutinin 3 is replaced by hemagglutinin 5, for example. And that sort of subsequently changes that formation of the virus. And, this is where, two different virus types can infect a cell. The genomic sequence actually changes, and then there's this replication of this brand new virus that we haven't seen before. So just to remind ourselves, what is the infectious period for influenza? So is it A, the first 3 days after symptoms appear? Or B, from the day before you show symptoms? C, until around about 7 days after symptoms begin, and sometimes even longer? Is it D, all of the above? Or is it E, none of the above? We'll give you a few seconds. How'd we go, Andrew? Oh, we've got a little cross section of answers, but certainly it is D. So 61% of you got that correct. According to the Australian CDC, the time people are usually most infectious are the first 3 days after showing symptoms. But people can infect others from the day before they show symptoms until around 7 days after symptoms begin, sometimes even longer, especially in immunocompromised individuals and in children. Children are germ machines, and when they contract influenza, they tend to be able to spread it to others for a longer period of time. So the majority of individuals who do become infected with influenza will show some symptoms, but certainly not everybody. We know that it's spread from person to person by inhaling those infectious respiratory droplets that are produced by an infected person when they're talking or coughing or sneezing. And we know that the transmission of influenza viruses can also occur through that direct or indirect fomite contact. We know that they can remain quite viable on people's hands for up to about 5 minutes and persists on hard surfaces, maybe for even up to 1 to 2 days. And people's hand hygiene perhaps has dropped off a little bit since COVID. Remember, we ran out of hand gel during COVID. Well, there's plenty of hand gel around now. So people don't seem to be buying it quite as much as what they were doing in COVID, but it's still really, really important. And it might amaze you, some of you, to learn that about 1 in every 3 adults have been observed to nose pick or eye rub each hour, and not just once per hour. There's been studies that have actually said that people touch their noses and mouths, 3 to 4 times per hour. So definitely we need to get back onto that hand hygiene. Certainly, like I said, young children definitely can transmit influenza for longer periods of time, and they're the ones that don't have very good cough etiquette. And so it's really important that we make sure that we're wiping their hands quite a lot. But, generally people that do have symptoms are managed conservatively, rest, fluids, a little bit of fever management if they feel that they need it. So looking at 2025, we had a bit of a bad season last year. So I think it's worth just having a bit of a recap of what the impact was. So this is Sentinel hospital site data. So this is not every hospital or every notification. So just bear that in mind. So this is just the Flucan Sentinel hospital data. So there was around about 17,000 admissions for severe acute respiratory infections, and around 50% of those were due to influenza. So around about 8,418 patients admitted with influenza to these Sentinel sites. About 46.5% of them were due to influenza A that was subtyped. So we're just not really sure what, flu type, whether it was an A or a B. We just have to go on the data that comes in. About 43.6%, so almost even, were admitted with influenza A, H1N1, and 9.9% with influenza A, H3N2. There was a bit of influenza B as well, and about 17% of those hospital admissions for influenza were due to influenza B. But thankfully, that despite the increased number of admissions with flu in late 2025, the proportion of children who have been admitted directly to intensive care or who have died has not increased significantly since the middle of the year. And it's been relatively consistent with the trends that were observed in 2024. So while reports do show that 8 children died last year of influenza, there were 701 discharge summary records that were incomplete or missing. So it could indicate that there may have been more. And once again, I will stress that this is just Flucan Sentinel Hospital site data. So that was in children less than 16 years of age. If we're looking at those above 17, 16 years of age, we can really see that there were sort of 1,238 deaths due to influenza in the first 10 months of 2025, comparable to the first 10 months of 2017, which was another horror flu season for us, but certainly higher than the first 10 months of 2019, which once again was a serious and severe flu season where we had quite high mortality rates for influenza. In 2025, the mortality rate for deaths involving influenza, both due to influenza and with influenza, was higher in Aboriginal and Torres Strait Islander people than non-Indigenous people. And although COVID-19 has been the leading cause of acute respiratory infection mortality across 2023 to 2025, the number of deaths involving influenza has exceeded the number of deaths involving COVID from August to October in 2025. So we are reminded that this infection is a serious infection and certainly does contribute to causes of death. So looking at a little bit more data, this is the burden of disease currently. So this is data to through to about the 4th of April 2026. There's about 25,684 laboratory confirmed flu notifications to the National Notifiable Disease Surveillance System. And we can certainly see here that this sort of dark blue dotted line is where we're tracking at the moment. But at the same time, last year, we can see this light blue line. So we had much higher case numbers at this same time last year. So 43.5, just over 43,000 this time last year. It certainly was a significant flu season in 2025, that is for sure. And this doesn't accurately reflect the burden of disease at all. We've got people out there who choose to just self-diagnose that they've got the flu, we're going to stay home for a couple of days, and they don't get tested at all. We've got people that are doing rapid antigen tests now that are available throughout all of the chemists and the supermarkets, etc. And so they'll be testing positive for flu on a rat, and then they just stay home. So this is just laboratory confirmed influenza. So don't get comfortable with the numbers, that is for sure, because they're not overly going to be accurate to what the true burden is. So, who's it affecting most? Well, certainly from all of those notifications, once again, the highest reports of flu is in children under 15 years of age. And this has been pretty consistent over the last 2 or 3 flu seasons. In the first quarter of 2025, there were sort of 12,234 notifications in children less than 15 years of age. And this year, for that cohort, there's been 7,286 notifications to the National Notifiable Disease Surveillance System. So what is actually circulating at the moment? Well, according to the Australian CDC Respiratory Surveillance Report, that was dated the 23rd of March through February through to the 22nd of March, influenza A unsubtyped has accounted for most cases across all of the age groups. But since early February, there have been an increasing number of influenza B notifications, which you can see in the red parts of the columns. there's a little bit of H3N2 that you can see there in the light blue parts of the columns across most of the age groups, although less so by the look of it in the older adult population, but a little bit more significant in the 5 to 19-year-old population. So it's going to be an interesting year to see what the year will hold for us. Is it going to be a H3N2 year with a little bit of a mix of B, or might it even change as the season goes on? But we know that this is a really costly disease to us. And so just to give you a little bit of an idea, what do you think is the estimated annual cost of seasonal influenza and its sequelae to the Australian healthcare system? Do you think it's A, at 598 million, or B, at 685 million, C, 787 million, or D, $828 million per year? So we shall see how we go, see how good you are at guessing. Wow, okay, yep. You're all appreciating that it's a costly disease. And the answer is actually D. And these are the results of a census calibrated model that demonstrated that the cost of influenza in Australia is estimated to be between 828 million and $884 million a year. According to the Australian CDC report that I referred to earlier, there was some interim Australian data as a part of the global influenza vaccine effectiveness collaboration, and they indicated that in 2025, people who did receive an influenza vaccine were about 53% less likely to visit general practice or be hospitalised with influenza compared to those who were unvaccinated. And this demonstrates to us that a highly vaccinated population can reduce this healthcare system cost. So less GP visits, less hospitalisations or hospital presentations. So it's just another good reason to really advocate for flu vaccines for people to be vaccinated against flu. So, the costs are because of all of this. And while most people who contract influenza may need a few days home to recover, some will require a visit to their GP or a hospital emergency department. Some will require a hospital admission, maybe even an ICU bed, and maybe even ongoing rehabilitation, depending on what their long-term sequelae might be. So particularly if they perhaps developed Guillain-Barré syndrome, for example, or if they had a cardiovascular complication and they had a myocardial infarct or a stroke, there's going to be this ongoing rehabilitation cost as well. But even those, sinus and ear infections, they're usually definitely a GP visit and then off to the pharmacy maybe for some antibiotics, etc. And we certainly know that pneumonia certainly is quite a possibility particularly for some individuals. But I think, this growing body of research and evidence which suggests that influenza virus infection itself could put people at increased risk for acute cardiovascular events like a heart attack or stroke, I think is really something that we need to take notice of, because these studies have actually found that people are about 6 times more likely to be admitted to hospital for heart attack in the week after coming down with the flu compared to any other time. And I think that's really something exceptionally significant. And there's been a lot of articles that have been published around the world that says that the risk of heart attack and ischemic stroke in patients aged 50 and older more than doubled in the 2 weeks after even mild influenza in those with few risk factors, and more than quadrupled in high risk patients with severe cases, with that risk staying elevated for at least 2 months after their influenza bout. So I think that this is something that we really need to stress to our patients, that influenza is a serious disease and it can lead to complications. So we know that some people are at increased risk of experiencing complications from influenza infection, and certainly these people include children, certainly those that are aged 65 and older, Aboriginal and Torres Strait Islander people. And, we really need to be very mindful that we must ask the question, do you identify as Aboriginal or Torres Strait Islander, just because they do have that increased risk? So who is at risk? There's a whole range of people with medical risk conditions that do put them at increased risk of severe influenza disease and possibly of those complications. So we definitely want everyone 6 months and older to be vaccinated, but we certainly do want to concentrate heavily on people with these types of medical conditions. So certainly check the table of conditions in the online Australian Immunisation Handbook, because this will also advise if the condition meets the eligibility criteria for funded vaccine, because not all conditions are going to be eligible for free flu vaccine. So who else is at risk? Well, really anybody, because like I said, flu doesn't discriminate. So these are the people that really should be considered for an influenza vaccine. So definitely people that are over 65 years of age, they are, getting free vaccine, definitely funded under the NIP. But there's some other long-term care facilities as well. So, we're looking at inmates of correctional facilities, which really should be focused on because they are living in close quarters. And certainly there's high rates of transmission of influenza and complications that have been seen during outbreaks. And so while not all groups are funded to receive a flu vaccine, please, please, please just keep recommending it to everybody that's aged 6 months and older. Being unfunded does not mean that it is unimportant. And I think we need to get that message somehow across to patients as well. So use every opportunity that you have to discuss flu vaccination with them. So if we're looking at, cardiac disease and, that risk of a cardiac arrest, we certainly know that there has been that increasing attention that's been given to this association between flu and cardiovascular conditions, and that's sort of been running for the last couple of decades. And apart from an elevated risk of cardiovascular mortality, it has certainly been linked to, like I said, both ischemic and myocardial complications, including, MIs, stroke, exacerbation of heart failure, myocardial injury, and in lower magnitude stress, cardiomyopathy, myocarditis, and pericarditis. So it's been, certainly observed that influenza virus replication occurs in arteries, and it's been shown to have a direct inflammatory effect on atherosclerotic plaques, leading to that plaque accumulation and instability. And once a piece of plaque becomes unstable, then it results in falling off the vessel wall, and then of course has the potential to cause a myocardial infarct or definitely a stroke. So we definitely want to stop people getting flu disease. What about flu and people with chronic lung disease? Certainly people with COPD are particularly susceptible due to that impaired mucociliary clearance, that dysregulated immune response, and that disrupted airway microbiota. So the risk of severe influenza-related complications such as pneumonia and acute respiratory distress syndrome and exacerbations of their COPD and other chronic diseases is markedly elevated in your COPD patients. So it does lead to higher hospitalisation rates, and it does lead to higher mortality. So that interaction between COPD and influenza is really multifaceted, certainly involving that compromised immune response and that chronic inflammation and that impaired lung function. So it's something definitely to speak to your COPD patients about. But what about those ones that have asthma? We know that flu is among the several potential triggers for asthma. And infection with a flu virus can certainly exacerbate inflammation of the airways and the lungs, and not only triggering the symptoms of asthma, but certainly making them worse. People are not more likely to get the flu just because they have asthma, but they are more likely to experience related complications such as, bronchitis and pneumonia, and may require hospitalisation as a result of the infection. And even people with mild or well-controlled asthma are at a high risk for serious health problems if they contract the flu. So the vaccine, however, is only funded for patients that have severe asthma, and that's those that require frequent medical consultations and the use of multiple medications in order to manage their asthma. So definitely another group to concentrate on. But we don't stop there. Diabetes is a huge risk factor, and it has more serious outcomes because of influenza. So we certainly know that the studies that show that diabetes is associated with a relevant increased risk for complications to both seasonal and pandemic influenzas, increased mortality, increased hospitalisation rates, probably about threefold higher than in the general population, even after adjusting for the most relevant confounders, including age. So in addition, diabetes is associated with a smaller but, significant increase in, that the fatality of those hospitalised patients. And the reason why diabetic patients are at increased risk of serious outcomes tends to be attributable for influenza and, as well as co-infections with other agents. There's, impaired immune responses, chronic inflammation associated with that hyperglycemia and or that insulin resistance. And according to Australian Institute of Health and Welfare, as of July 2025, last year, only about 46.4% of regular clients in general practice with diabetes had an influenza immunisation status recorded in their GP record within the previous 15 months. So, as healthcare professionals, we understand that a person with diabetes is at increased risk of severe outcomes from flu. However, maybe it seems the patient does not understand that risk. So, we need to ask, is the patient recommended and offered an influenza vaccine each year? Or is it being recommended and offered, but the patient is declining? And if the patient is declining, we must ask why and try and alleviate those fears. Maybe they've heard a lot of myths or something that's putting them off. But we really need to think about patients with diabetes. So pregnancy, pregnant women, increased risk. We definitely know that the viral clearance mechanisms from the lung are suboptimal and involve hyperactive and innate and adaptive immune responses that generate that widespread inflammation. And pregnancy-related adaptations of the immune and the cardiovascular system appear to result in that delayed recovery post-viral infection, which in turn just promotes a prolonged inflammatory characteristic, and that increases disease severity and causes maternal and fetal health problems. So we certainly know that, vaccination against flu in pregnancy not only protects the woman, but also the baby. So the babies, as we know, we can't vaccinate under 6 months of age. They're just too young to be getting a vaccine. So they do rely on those maternal antibodies. So if you are having trouble getting pregnant women to be vaccinated against influenza, certainly have a bit of a chat to them about the benefits for, not only themselves, but also for their little baby. So flu vaccination for travellers, another really important group. We certainly know that seasonal influenza is the most frequent vaccine preventable infection that travellers have. And so influenza vaccine should be part of that pre-travel advice for all of the travellers. And we certainly know that there's, several changes in our global world that contribute to this. And, we've got more and more people traveling, and flu travels on aircraft. Don't you worry about that. And certainly in, airports, as you're sitting around waiting for your flight for 3 hours before you take off, we have a lot of visitors coming into our country. We add to that the 2.5 million Australians who are traveling over to overseas destinations and then returning home. But certainly it's a conversation to have as you would be having to discuss COVID vaccine pre-travel, or Hep A or Hep B, or even your MMRs. So flu should definitely be part of that conversation as well. So our final poll for the evening, who is recommended to receive 2 doses of influenza vaccine 4 weeks apart in the same year? Is it healthy children aged 6 months to less than 2 years receiving flu vaccine for the very first time? Or B, children aged 6 months to less than 9 years with medical risk factors and they're receiving flu vaccine for the first time? Individuals having flu vaccine for the first time after receiving a solid organ transplant, a hematopoietic stem cell transplant, or CAR T cell therapy. And those women who have received a dose of influenza vaccine already and then become pregnant in the same year. Is it E, all of the above, or do you think it only relates to B and D? But we'll see how you go. So how did we go, Andrew, with that? Oh, well done. Well done. There was a lot of reading on that slide, so you had to get your head around it a little bit. But it is definitely all of the above. So the ATAGI guidelines for and the recommendations for this changed this year. So certainly hematopoietic stem cell transplant, solid organ transplants, those that have received CAR T cell therapy are at increased risk of severe flu. Um, Definitely now they have changed it. We used to vaccinate all babies 6 months to less than 9 years with 2 doses in their first year of ever receiving flu vaccine, but that changed this year. So if they're a healthy child, they only get the 2 doses 4 weeks apart. If they're between 6 months of age and less than 2 years, but if they do have medical risk factors, then from 6 months to less than 9 years, then yes, they would receive 2 doses of flu vaccine 4 weeks apart if this is the first time that they're ever receiving flu vaccines. So just a change to be aware of. So just check your ATAGI guidelines. So government funded, this has been released in the ATAGI statement. So 2026, these are the groups that are going to be receiving free flu vaccine. However, like I said, there are other groups that do not qualify for funded, but there's also some nuances amongst the states and territories where they have their own programs as well. I'm from South Australia, and we certainly have a free flu program for people that are experiencing homelessness. So whichever state and territory you're in, just double check with your health department with any state funded programs. So when should we administer? Well, this is a bit of a tricky question, isn't it? Because since 2019, we really have seen higher rates of interseasonal flu activity. So our flu season is often unpredictable. So ATAGI, the Australian Technical Advisory Group on Immunisation, states that annual influenza vaccination is the most important way to prevent influenza and its complications, and that these viruses are undergoing constant, antigenic drifting. So it is important to get vaccine every year. So while we want to time vaccination right, so people have optimal protection during the peak flu season, honestly, if you have access to flu vaccine, just offer vaccination. We just need to get these vaccines into people's arms and into little children's legs, little babies' legs. We need to perhaps become a little bit better at normalizing this flu conversation. It's important. It's an important vaccine. It's a serious disease. And we just can't, recommend enough that a recommendation from a healthcare professional, particularly during a patient conversation when you've got them right there in front of you, has shown to be really highly effective in increasing vaccination rates. So just try and take every opportunity that you can whenever you've got a patient in front of you. So a quick look at the virus composition, vaccine composition for this year. We certainly always know that there's going to be a H1N1 component, a H3N2 component, and this year there's just the 1B Victoria lineage component. The World Health Organization and the Australian Influenza Vaccine Committee have recommended that the B Yamagata lineage component is no longer seasonal influenza vaccines, as this lineage has not been seen since 2020. So all vaccines used in Australia in 2026 are actually trivalent vaccines, not quadrivalent vaccines. And you will notice that there is a difference between the egg-based, sorry, I didn't change out quadrivalent in the egg-based or the cell-based titles. So the trivalent vaccines. So you will notice in the difference between the H3N2 strains in those two different types of vaccines, and that's really because growing influenza viruses in eggs might produce changes to the viruses called egg adaptation, which can cause differences between the viruses in the vaccine and the strains that are circulating around. So H3 is a bit of a hard nut to crack. It's very difficult to grow in eggs. It's very slow growing in eggs. So and it wants to change the virus too much. So cell-based vaccines don't get that change. So, oh, I didn't change the title of this slide either. God, I'm falling behind on my tasks here. So what are we using this year? So this is the table from the ATAGI statement. So just make sure that you're getting the right vaccine out of the fridge. What's funded, what's not funded in the white boxes is what's funded. And what you will see is what's available across, if you're going to a pharmacy or anything like that, private scripts, this is what you could get. So just be aware with Fluad this year, it is now registered to be used for people aged 50 years and older. However, it is only on the NIP for those aged 65 years and older. And so for the first time, we are going to be seeing Fluad available on the private market. So for people aged between 50 and less than 65 years, if they wish to purchase a flu vaccine, then this is actually available for them. We also note this year, FluMist is a live attenuated nasal spray vaccine. It's now available in Australia for the first time, and so we will have a little bit of a look at that. Flucelvax is obviously here again, so that's the cell-based vaccine, and that's going to be on the private market. It's on the private market, but just remember for Flucelvax, it is actually registered for use in infants from 6 months, but on the NIP, it is for certain groups aged over 5 years of age. So there's 2 enhanced influenza vaccines that are available for older adults. You've got your Fluad, like I said, 50 to less than 65. It's not funded under the NIP, but Fluad is funded for the 65 and overs. You've also got Fluzone High Dose, which is registered for use in people aged 60 and over, but it is not funded on the NIP. So available on the private market if somebody wishes to have a high dose vaccine. The Fluad is an adjuvanted vaccine, so that adjuvant excites the immune cells to be a little bit more responsive in older people. Fluzone High Dose has 4 times the amount of antigen per strain than a standard egg-based vaccine. So FluMist, like I said, it's a live attenuated vaccine delivered via a nasal spray. People with young children may find that this might be a little bit more palatable, knowing that their child's not going to have an injection. It'll be interesting to see how well they tolerate a spray up each nostril. So we'll wait and see. Look, FluMist has been used quite extensively since 2003 in the Northern Hemisphere. So this is not a new vaccine. This vaccine has been around for a very long time. So let's be mindful of the language that we use when we're talking to parents about vaccines, because as soon as you put in it's a new vaccine, they think their children are going to be guinea pigs. So it's not a new vaccine. While it's a live attenuated virus vaccine, certainly the surveillance overseas has found that there's been no cases where the vaccine nasal spray has caused influenza. So you will see here that some states have decided to fund this. The funding is a little bit different in different age groups, etc. So please check your local health department to whether or not you are offering it or not offering it for free. Otherwise, it is going to be on the private market if parents are wanting to purchase it, if you are in a state or territory that is not funding it. It is contraindicated in people with moderate or severe immunocompromise. They should certainly receive an activated influenza virus vaccine. It is not contraindicated in pregnant people. So if you do have a young teenager that is pregnant, it's not a contraindication. However, an inactivated flu vaccine would certainly be preferred. But all of these vaccines can be co-administered with other vaccines. Live attenuated influenza vaccine can be given at the same time as well, or at any interval before or after other commonly used vaccines, including live virus vaccines. So vaccine efficacy and effectiveness really will depend on the immunocompetence of the individual that we're vaccinating and how well the vaccine virus strains actually match the circulating strains. Both of the enhanced vaccines that we have found to be a lot more effective in preventing hospitalisation from influenza or pneumonia than a standard dose influenza vaccine. So for your older patients, please, steer them to having one of the enhanced vaccines rather than a standard egg-based vaccine. However, if they have received a standard egg-based vaccine already this season, you do not need to bring them back. There is no recommendation to bring them back for them to receive an enhanced vaccine dose. So, regardless of what vaccine type, whether it's standard egg-based, high-dose egg-based, or cell-based, a percentage of vaccine recipients will experience adverse events. Whoops, there we go. Next one. Yep, adverse events. But most of them really are short-acting. People shouldn't be, too unwell with them. Certainly the live attenuated vaccine can just cause some upper respiratory and nasal symptoms, runny nose, maybe nasal congestion or a little bit of a sore throat maybe. But certainly rare side effects post-influenza vaccine, are there. But remember your doctor's ABCD, you've got an anaphylaxis kit, you know how to handle an anaphylaxis. So people with egg allergy, even history of anaphylactic egg allergy, can be safely vaccinated with egg-based vaccines. We just need to do better. I'm going to rush through these last slides because we are really running out of time here. But I will get to answer your questions in writing. I'll get Andrew to send them all through to me so we don't hold you up too much tonight. But our coverage data is really, really, really suboptimal. This is obviously last year's data. Can we do better this year? Think about what activities you can be doing in your general practice that might increase vaccine uptake. Certainly use your practice nurses. There's a lot of practice nurses that are listening to this webinar. Hand on heart, you're the best things that have ever happened out there. I know that you are willing to vaccinate. You have got the expertise to vaccinate. Unfortunately, the funding just does not allow nurses to run autonomous um, clinics within general practice. There's just unequal remuneration for people putting vaccines in arms. Council nurses don't get paid 1 cent to put an adult vaccine in an arm. These are great big missed opportunities for increasing vaccine uptake, and hopefully governments are looking at this and are going to be making some changes, because we've got experienced providers out there that are being underutilised. So just remember, flu can be really serious. There's funded vaccine available for certain groups. Have a look at your ATAGI statement that has come out this year, just so you can see what the new recommendations are for flu season this year. But our take-home messages really offer it to everyone aged over 6 months. Undertake that robust pre-vaccination checklist to identify those at-risk individuals. Use every encounter to discuss an influenza vaccination, and use every influenza vaccine encounter to discuss other recommended vaccines. And remember, a vaccine in the fridge is just potential. A vaccine administered is protection. So vaccines work, and make sure that you report your influenza vaccine encounters to the AIR. So I think we've probably got a zillion questions in the box by the looks of things.
We do finish on time at 7. So
Correct.
as you said, Angela, all the questions will be answered. So
Yes,
we'll go through that in the next couple of days. But,
correct.
we've probably got time for just a couple, right? We should have a couple.
Ah, perfect. Okay.
So let's talk about, and I've looked at all the questions. A lot of them have been answered by you as you've gone through your presentation, or have been answered in the chat. So thank you for that. And thanks for.
Good.
So for children under 5, where the vaccination rate against flu nationally is around 26% last year, and it was about the same the year before as well. Um, so what do we have to do to increase that vaccination rate? And what's your message to parents? The healthcare professionals are doing the best they can, but it really falls onto the parent to bring the child in to be vaccinated. And what happens if you were to choose South Australia, for example, where you have now 2 funded vaccines? Do you go with the tried and trusted and NIP approved, or do you give the option of a intranasal spray?
Okay, so we'll start at that point first. Part of your valid consenting process is that you must explain all of the alternatives available. Now, I do know from SA Health that children that are going to be eligible for flu mist, that will be the vaccine that is going to be preferred. But if the parent does not want it, they want the child to have an injectable, they can have an injectable. But it's going to be offered to them as the preferred vaccine, if you like. In regards to increasing vaccine uptake, I think there needs to be a much bigger awareness campaign. Flu doesn't really seem to be a sexy enough topic for media to pick up on. Although there is a bit of media around now around, oh, come and get your vaccine, etc. But there's not really been a campaign for flu for quite a while. And for many, many years, I would be doing a lot of talking to parents of very young children, asking them about vaccinating their child against influenza. And they were actually very surprised that they should get their child vaccinated, and very surprised that there was free vaccine. And they had said to me, well, God, never heard that. And my doctor's never said anything. So we understand that health providers are really, really busy people. And I think this is where, maybe the problem lay, is that they're under the pump so much to get through the patients that they need to get through, that they just are not having the time to see the patient for what they've presented for, as well as then get into a long discussion around flu vaccines. And I think maybe the one thing that the providers can do is obviously have the consult with the patient for whatever they've arrived for, and then say, look, we need to have another discussion around the vaccine program for your child. With flu season approaching, could you make another appointment on your way out the door for a time where you can come in and chat to us? Something. We just need to be able to get the messages out and that healthcare recommendation out. Whether or not it's the nurses that might be doing something with the child, either giving them a nebulizer or whatever, chatting to the parents, and then just weaving vaccination chat into that conversation.
Okay, maybe just one last question because we are over time. I apologize for keeping everybody here. So there's been on the news quite a lot that for the first quarter of this year, from 1st of January through the 31st of March, which is not the flu season, but we're at 25,000 laboratory cases. And there's been a lot of, hoo-ha about that. And they say that a lot of that is driven by the K strain, sort of bumping that up. If I look back to last year, same time it was 47,000. So it was almost
Yes,
double. So last year was worse, and that wasn't driven
yes.
by the K strain. So what's your kind of, and last year was just under 503,000 cases. So it was the biggest uh, flu season we've had ever, I think. So what's your message to healthcare professionals that see patients or see individuals in pharmacy to stress the point that flu is a serious disease and I need to vaccinate you now.
Yeah, look, absolutely. I think, it is exactly that message of, look, flu is here. It looks like that, maybe this subclade K, or super K as it's been called, has been the cause of most of the influenzas they're predicting. It was certainly how we left the end of last year. I fell victim to it at the beginning of December last year. I was one of those little humps that you saw on the graph of last year. So it seems to have been what has carried on throughout interseasonal. Um, it's not a more serious strain of flu, but they're saying it is more transmissible. So it's going to be really interesting to see what comes through from the Northern Hemisphere. South Australia and New Zealand were the first to find subclade K. So it's going to be interesting to see whether or not another strain actually overtakes it throughout the course of our season or not. But we'll be watching very, very closely.
Okay, thank you. So time's up, I'm afraid. But as I said, all the questions will be answered over the next week, together with the link with the recorded webinar. So thank you, Angela, for presenting tonight. Thanks for the audience for all their questions and engagement. So I've been looking at the chat. So, there's been, nearly 100 comments posted. Our next meeting as an IC disease webinar is on the 24th of June. That's a pneumococcal, and hopefully there's going to be some more news around pneumococcal vaccines. So hopefully, and we do have a RSV expert meeting on the 15th of June. So that's the first day of the CDIC meeting. So you can find it. It's a dinner meeting. It's for 2 hours in the evening after the welcome drinks. So we had that last year. We're going to run it again this year. So if you're attending the CDIC meeting or in Melbourne, please have a look on our website and register. And if you can't attend on site, then happy for you to attend online as well. And thereafter the CDIC meeting, we have our 10th annual immunisation forum, which is on the 18th. It's a full-day event at the Marvel Stadium. It's the same stadium it's the same venue as the CDIC. So look for those details as well, and we'll communicate those out. So with that, I'm probably just going to end now. There's no evaluation form, and as I said, I'm doing the IT tonight, and I don't know how to send you the evaluation form because I don't know how to reconciliate the emails through the Zoom platform, but I will do that in the morning and send that out. So from me, it's a thank you. Thanks for joining. I hope it's been insightful. And again, thanks very much, Angela. You might want to say good night to everyone because I will say
Absolutely. Thank you, everyone, for joining us. And you did very well, Andrew. Top
you did
marks.
you did better. So thanks, everyone. Stay
Yeah,
safe.
thank you, everyone. Stay well.
Okay. See you next time. Bye bye.
Bye bye.